Assalamu alaikum. Good afternoon, good morning to wherever you are joining us from different parts of the world. We welcome you to yet another session of the Population Health and Wellbeing series. I'm Dr. Sohaila Chima. I'm the Assistant Dean for the Institute for Population Health here at Weill Cornell Medicine-Qatar, and also an Associate Professor of Clinical Population Health Sciences. A very warm welcome to each of you. Just as a reminder, the objectives for this series are to discuss contemporary and critical topics which are relevant to healthcare, medicine, and population health, and also to examine evidence-based germane practices, which for public health and patient care. We also look at describing opportunities and challenges in the evolving face of healthcare and population health. Just some housekeeping rules. Your cameras and microphones have been turned off. Please use the Q&A feature to type your questions and comments. You can also use the chat. So if you put your question or comment in the chat, we will be able to view them. So you can use either the chat or the Q&A tab to put in your questions and comments, and we will address all the questions at the end of the session. I will be moderating the session. So, of course, this is an accredited activity for healthcare professionals, and you will be able to claim credit as per your attendance. So this is an important notice for practitioners who are licensed in the state of Qatar. So you are already aware about this notification from the Ministry of Public Health, the Accreditation Section, Department of Healthcare Professions. So you need to please ensure that your Qatar ID and Ministry of Public Health license number, they match the registration and licensure details in the MOPH database. This will allow us to record your attendance accurately as required by the Department of Healthcare Professions. So please kindly, if you haven't already, update your profile on Cloud CME. So of course, Cloud CME is Cornell's registration portal. Once you've signed in, click the yellow My CE Continuing Education button to the right, select Profile, and review, update the fields as required. The deadline to update your profile for this session is today. So kindly, please just do it now. So talking a little bit about evaluation and certificates, the post-activity evaluation will be available in your Cloud CME account by May 27th. And healthcare practitioners who are licensed in Qatar will only receive their credits once the QID and MOPH license number has been provided. You'll receive an email notification once the evaluation is available in your Cloud CME account, and your certificates will be available for download once you complete the post-activity evaluation on the Cloud CME portal. So now on to the session. So I'm very excited to introduce our speaker for today, Dr. Amy Mechley. She's going to be talking about lifestyle medicine, focus on women's health. On introducing Dr. Amy Mechley, she earned her medical doctorate at the University of Cincinnati College of Medicine and completed her residency in family medicine at the University of Utah. She's a practicing lifestyle medicine, direct primary care, family medicine physician, an entrepreneur, clinical consultant, and an educator. She serves as the chair of the board of directors for the American Board of Lifestyle Medicine and the International Board of Lifestyle Medicine. She's an active speaker for many organizations, including the American Academy of Family Physicians and the American College of Lifestyle Medicine. Her career as a physician is grounded in servant-led principles. Dr. Mechley is a healthcare expert who takes innovative approaches to tackle some of the most challenging concerns in healthcare today. With extensive experience advising healthcare systems, governments, and physician groups, she has been instrumental in designing population health initiatives and primary care reformations. She is dual board certified in lifestyle and family medicine and has achieved the status of lifestyle medicine intensivist. It is her interest in aligning her focus of lifestyle medicine principles within primary care that has led to her practice, IFC Direct Primary Care in Cincinnati, Ohio. Dr. Amy Mechley, a very warm welcome to you, and thank you so much for doing this session for us today.
Dr. Chima, my friend, thank you for welcoming me. And thank you to the Weill Cornell Medicine Institute for Population Health.
It's our pleasure.
Yes, we had the pleasure of being together recently, and I am thrilled with the advances that you're making and the discoveries in this area and the application of truly evidence-based lifestyle medicine. Just very exciting to be a part of this. And again, thank you very much for welcoming me. I am going to go ahead and get started. So I will share our slides because I hope to have time at the end for questions, because that is really why we're here, is to help understand how we can lift together the evidence of lifestyle medicine and the clinical application of such. And specifically today, I'm absolutely pleased to be speaking on the focus of women's health. So my goal is to go through some updates, some things that have caught my attention in the literature and the research over this past year to 2 years, specifically focusing on women's health. There we go. So again, in disclosure, I have nothing specific to disclose. I've been an advisor for many institutions, many panels, but any relationship, as you see there, has ended. I was speaking on a podcast yesterday and they told me that I was a bridge, and that's been a big compliment. So again, I feel like I'm a bridge between groups of people that are moving forward, specifically in lifestyle medicine. That's really my biggest disclosure. So our objectives today is, again, just to go through the clinical topics that I've chosen in lifestyle medicine in areas of women's health. We're going to identify current research in the different areas of lifestyle medicine. And then we're going to talk a little bit about healthcare disparities and where we can lean in, I think, a little bit further to progress our understanding and impact, specifically in women's health for lifestyle medicine. So again, this is just a summation. It's updated information that are common for women's health, but we like to use the term lifestyle first. So it's not without the complete knowledge of what we would consider allopathic health or Western medicine or traditional healthcare or other areas that we would consider maybe adjunctive healthcare. But what we're looking at is a lifestyle medicine first approach or lifestyle first approach. It just makes sense. And we could talk about that after, what that means to me. But again, this illustration really speaks to all of the pillars of lifestyle medicine that we all practice, the different 6 pillars. And we can organize these in a different way. But again, just for communication's sake, we know that paying attention to all these areas is really important to obtain optimal health. That's another word that I've really started to use more and more these last 10 years. It's optimal. Optimal to me means for our patients, what is optimal for them? Not what is perfect, not what is completely attainable or unattainable, because in lifestyle medicine, there's always more that we could possibly think about changing our own health behaviors. But in our current situation, with our current environment, what is optimal for us in these areas of health? And today we're going to see, I'm really going to have a focus on nutrition. It's not because I intended to do so, it's because we have a lot of evidence-based research and the impact of nutrition is quite significant. And I'll show you that through the next presentation and through the slides. So first, we're going to start with a very interesting study. It was a recent modeling study conducted using 3 types of dietary patterns and their effect on lifespan, and a little bit of quality of life, but mainly just lifespan. The 3 diets that they looked at, the dietary patterns, were a typical Western diet, then an optimized diet, which meant if you could optimize the areas and all of these nutrients, what would that look like and what would that do to your lifespan? And then at a 50% point in between, it was interesting how they did this study, right in between was the feasibility diet, knowing that maybe our patients and ourselves can't get to an optimal 100% diet, what they use here, the optimal, a little different than I use it, but the absolute perfect diet, so to speak. And again, there is no perfect, but I loved how they talked about a feasible diet, which was only a 50% switch. And globally, dietary risk factors are estimated to cause 11 million deaths globally and 255 million disability adjusted life years annually. You'll see those in the research called DALYs, D-A-L-Y, and it's disability adjusted life years. So dietary risk is so significant here. And that's why you'll see I'm going to emphasize diet. I always say it's one of the biggest levers that we can pull when it comes to health outcome change. So the health gains from diet change are generally linked to gains from reduction in cardiovascular disease, cancer, and diabetes. And they all, these are the leading causes of mortality globally in both men and women. Again, I'm going to highlight women here, but a lot of these areas we're going to look at it does affect both of the genders significantly. So here in the slides, I'm going to see if I can get a little laser pointer. There we go. So you can see first I want you to look at the key here, right in here. So the way that they chose to look at the impact is there was for the feasibility diet, again, and the optimal diet the same, there was an increase in legumes, whole grains, and nuts. There was a decrease in red meat, processed meats, sugar sweetened beverages, refined grains, and eggs. And there was an increase in fish, fruit, and vegetables. No real change. They didn't see a significant change when they changed milk, white meat, and added oils, interestingly. And again, the outcome that they're measuring is just the lifespan. But if you can see here, I'm trying to get to luckily I have a touch screen here. You can see here at age 20, there is an almost 2.5 increased years of lifespan just by changing your diet at age 20. And interestingly enough, what I like is at age 60, you can also get an almost 2-year, 1.75 year increase in life expectancy for changing your diet at 60 years of age. So again, it's never too late to change to have a significant impact in how your health is going to be affected by diet. Okay, there we go. So let's talk about our first subject matter, which is osteoporosis. Some of the guidelines that we've been given, and they're still very well, is to stop smoking, eat well, and be active. We know that has an impact on osteoporosis or thinning of the bones. But I want to start with a quick question, and this is where we're going to do a poll. So what is the main cause of fractures? So these are your choices. Is it low bone density, falls, low calcium and vitamin D, or a whole food plant-based diet? So thank you so much. We put the poll up. So if you guys could go ahead and start. Thank you. Start voting and we can see. Beautiful. I love this. I love this. I love this because there's so much good information and there's so much really good information about this, but I'm going to highlight something. So that's great. We can go ahead and end the poll and then discuss it. So about 35% of everybody says low bone density, about 27% says falls, and then 37% says low calcium and vitamin D, because there's micronutrients like low calcium and vitamin D are very traditional for our counseling patients. But interestingly enough, and this is what I'm excited to show you. There we go. The main cause of fractures is falls. And it's really important that way we speak and think about, I'm going to take that off there, what's going on when it comes to fractures. We get caught up in the disease state itself, which is osteoporosis, which is thinning of the bones. That in of itself does not cause fractures. It's actually the person falling that causes the fracture. And to give a little bit more credibility to that, the statistic that I found is in the 20 years from age 60 to age 80, hip fracture risk increases 13-fold. This is both in men and women. So hip fracture risk increases 13-fold in those 20 years. But the age-related decline in bone mineral density accounted only for a 2-fold increased risk. So the contribution of declining bone density to the exponential increase in hip fracture risk with age is actually relatively small. The vast majority of our age-related rise in hip fractures appears to have little to do with the measured density of our bones. In other words, if we don't fall, we're not going to break it. Still means we need to increase the bone density and we need to maintain bone density. But how are we going to decrease the falls is, I think, what we really need to be focusing on, and how we decrease the fracture of the how we decrease the main cause of fractures, which is falls, is exercise. And this is what I think, again, is really exciting to understand. So sarcopenia is the lack or the minimizing of bone or of muscle on our bone. So as we age, we naturally will reduce the muscle that we have. So exercise not only increases that muscle, but it really decreases our chances of falls. So even though it is important to get enough vitamin D and enough calcium, and it is important to maintain and monitor our bone density, looking at the actual causation, it has to do with falls, and then it has to do with exercise. So exercises reduce the number of falls over time by 23%, and the number of fallers by 15%. I want to talk about some specific exercises that's fun, that are, again, I like to enjoy. And that's one of the things that I talk to my patients about, is I always want them to choose something that is enjoyable, because that's the way that's going to be sustainable. But Tai Chi appears to reduce the falls by 19% alone. So doing Tai Chi is 19%. And Tai Chi won't usually typically get a lot of extra bone. It's not a weight, it is a weight bearing exercise, but it's not a resistance training exercise. But that in of itself, and again, I think it has to do with the balance. Balance and functional exercises like sit to stand may reduce falls by 24%. I hope you guys can see me. I'm actually going to use my chair here. And maybe you can't see me, but I want to show you this, how simple it is. A sit to stand exercise you can do with your patients. And all it is, I'm seated right now in my chair. I'm going to have my hands up in the air if I can. Again, not to use my hands to assist. And I'm going to stand. And then I'm going to sit and I'm going to touch my bottom on my chair, but not put it there and then come back up. So that in and of itself, a very simple sit to stand exercise may help reduce falls by 24%. That's a functional exercise. Multiple exercises, typically they have to do with balance and functional exercises, and then you add strength training into it, and the studies show that they may reduce falls by 34%. So again, all the other options in the question were important, but I just loved understanding more about what was so important about the exercise in reducing fractures, which is what we really want to do. It's not just by getting our DEXA scans, we actually want to reduce fractures. So in osteoporosis now, I want to talk about some nutrition. And you'll see there's going to be a theme coming up, because I hit on a little bit of a theme as I was going through the literature. I shouldn't say a theme, it just kind of came to me. It was obviously shown. We're going to talk about soy. So the general population-based data suggests consuming soy products at higher levels is increased with bone mass. And interestingly, there's no data on supplements, protein powders, or pills. But many times, and I'm thinking in your office, you see this too, most of us tend to want to go to the unnatural, the processed, the advertised health benefits of different types of products. I tend to tell my patients on a regular basis, let's go back to what was part of the earth to begin with, as we are part of the earth. That probably will be much better for us. And here's a study that shows that. So just in general, some data around soy. Soy milk was compared to transdermal progesterone cream, and the control group lost bone, which we know that we're going to lose bone over time. The progesterone group lost less than the control group. But interesting that the soy milk group, which was 2 cups of soy milk a day, improved bone density. There was a lower risk of bone fractures associated, which is a single serving of soy a day in another study, and that was equivalent to 5 to 7 grams of soy protein. Or 20 to 30 milligrams of phytoestrogens. And again, that's in 1 cup of soy milk a day. So a serving of soy could look like a cup of soy milk, or tempeh, or edamame, or the beans themselves. So again, lots of options to help get soy into our diet. And it's a little powerhouse. So we're going to switch now to breast cancer. And first, I'm just going to talk about breast cancers around the whole world. And this comes from the Globocan 2020 from the World Health Organization. And according to the World Health Organization, malignant neoplasms are the greatest worldwide burden for women, estimated at 107 million. The DALYs, like we mentioned before, the disability adjusted life years, 19.6 million DALYs are due to breast cancer alone. And breast cancer is the leading cause of cancer or death for women globally. So this is significant, and it's growing, as we discussed. Breast cancer incidence and death rate have increased over the last 3 decades. Oh, there we go, right there. Between 1990 and 2016, breast cancer incidence more than doubled. in 60 of the 102 countries. Some of these countries were Afghanistan, the Philippines, Brazil, Argentina, whereas deaths have doubled in 43 of the 102 countries like Yemen, Paraguay, Libya, and Saudi Arabia. So unfortunately, we're seeing more, not only more breast cancer, but we're seeing the death from breast cancer increase. So we need to, this is a great area for focus, which I think there's been a lot of research here. So I'm going to highlight just a little bit. Per our friends at MD Anderson, the statistic is out there that about 5 to 10% of cancer risk is from genetic defects. The reason I want to highlight this is we're getting very excited about genetics, and I am very excited as well. But I think we have to be thoughtful about where we're putting our attention and our resources. So if we know that only 5 to 10% is genetic risk, which is significant, is important, the majority of cancers are not related to our genes, but they are related to how we express our genes. The greatest majority is a combination of diet, lifestyle, and environmental factors. So again, we're going to look at our friend, the nutrition button, and how much of cancer risk in general is from nutrition or dietary risk, 35%. So again, when we're looking at where to put our attention and time, although many things may be important, when we're counseling our patients and they want to come in and ask about the latest genetic testing for cancer risk, important discussion, but please be thoughtful that 35% of the risk from cancers comes from nutrition. So talking to them about what they're putting in their bodies. Is it nutritional? Is it not actually food? 76% of what is eaten in the United States is not actual food. And the way that I describe food is something that is there to be nourished and something that it comes from a primary source from the earth, as opposed to a factory. So that's a lot of what we're putting into our bodies is processed food. So that, speaking to that, I think is very important. So again, here comes our friend soy. There's been a lot of controversy about women in breast cancer and whether they should or should not be intaking soy. I want to talk about these receptors. I'm going to get a little scientific for a moment. We have now understood the existence of a newly discovered estrogen receptor, which means there are two types of estrogen receptors in the body. The second one they're naming estrogen receptor beta to distinguish it from the original estrogen receptor. And unlike our own body's estrogen, soy phytoestrogens peripherally bind to the beta receptor. And this is important because it's a selective estrogen receptor modulator, which has pro-estrogenic effects in some tissues like bone, but anti-estrogenic effects in tissues like breast. So again, same substance, two different receptors, two different effects. Soy appears to function as a natural selective estrogen receptor modulator. So the estrogen blocking abilities of phytoestrogens can help explain their anti-estrogen effects. And so how a target cell responds depends upon which type of estrogen receptor they have. And this may be the key to understanding the health protective benefits, potential benefits of soy phytoestrogens. So that gives you a little scientific understanding, but essentially, yes, women who are at risk or have had breast cancer. Now, there are certain subtypes of breast cancer, so we need to be careful with this, but in general, it is absolutely okay for them to eat soy because we understand there's two different types of receptors for those phytoestrogens and how they react in the body. So it can be protected to the bone and it can be protected to the breast by having anti-estrogenic phytoestrogen effects. So I know that's a little technical, but I really wanted to get that out there to help us understand why it's okay for people with breast cancer to have soy. I have a very close friend, he's a male who has breast cancer, and I did a lot of research for him around this about 2 years ago. So flax seeds, you're going to hear me talk a little bit about flax seeds. So I want you to see this studies I'm going to talk to you about are breast cancer prevention. There's a small study. Some of these are very small. So we have to be thoughtful about our research. Is this, how impactful is this? Or is it directionally correct? I like using that word, like it's directionally correct. We need to understand more about it, but we're being shown a certain direction and understanding. So this was a small study by the National Cancer Institute of high-risk premenopausal patients, women that were premenopausal and high risk for breast cancer by needle biopsy. So they had some precancers or very early cancerous breast cancer tissue found in the breast. They were given a teaspoon of ground flaxseed every day for a year. I'm going to pause here because I want to underline the fact that this was ground flaxseed. When we ingest flaxseed, it is important to, prior to ingesting it, to grind it then and there. If you buy already ground flaxseed, it really starts to lose some of the nutrients after it's ground. Some of the EPA, DHEA, and just the different elements that are so protective in flaxseed. So again, freshly ground flaxseed. So after the women were given a teaspoon of ground flaxseed every day for a year, a repeat needle biopsy showed that 80% of the 45 women, again, only 45 women, there's a certain biomarker associated with cancer, specifically called a K167, and this went down. And there was noted overall less cellular proliferation in breast cancer tissue and fewer precancerous changes. So again, small study, but directionally shows us, I think, the power of freshly ground flaxseed when it comes to breast cancer prevention. There's also another study I'll mention, the Ontario Women's Diet and Health Study that was done in Canada between 2002 and 2003. And there was a group that did monthly and weekly and daily consumption of flaxseed. And it was about 32.5 grams in the flaxseed. And then some of them that did flax bread, which was about 2.5 to 5 grams of flaxseed. All of the groups were associated with a significant reduction, anywhere from 18 to 24% for breast cancer. So interesting little powerhouse here in flaxseed. Very simple, easy to get for most of us, and just to grind it. What I do is when I make a smoothie or something, I'll put it in my blender first, grind it up, and then add some ingredients over the top. Or you can just buy a little coffee grinder, and that grinds flax seeds really easily. I've tried to do it myself with my hand, and it's not as simple as that. So now I'm going to talk a little bit about breast cancer adjunctive treatment with flax seeds. And again, this is adjunctive treatment with other treatments. So between the time of the first biopsy and surgery, patients were randomized, again, another small study, to either treatment or the placebo group. So they either got a flaxseed containing muffin or a controlled placebo muffin. So they were both muffins with seeds in them. One had to do with the flax seeds. And why flax seeds? Flax seeds, again, are the richest source of ligands, with levels up to 800 times higher than that in the 6 other plant foods tested in this vegetarian diet when they were looking at adjunctive treatment. In the 5 weeks of flax or no flax, tumor cell proliferation went down, cancer cell death went up, and another marker called a CERB2, which again is a marker for cancer aggressiveness and potential for forming metastases and spreading, that went down. So again, really exciting data, small, again, because most data around nutrition tends to be small, but directionally very exciting. And I think they're putting flaxseed through some larger trials now, which is exciting. But wanted to get that out there, though, since we know that. So let's talk about cancer survivorship. And again, we're still talking about breast cancer. But individuals who have the healthiest diet had 11 to 24% lower risk of cancer death than those with the least healthy diet. And my apologies, that statistic is all cancers. I said something about breast cancer, but this statistic itself is with all cancers. So again, I'll restate that individuals who have the healthiest diet and in these subgroups, and I've got all of these studies in my resource slides. Actually, there's more than these studies in the resource slides. I put together, I think there's about 20 resource slides in the end of impactful research that I've been looking at that I thought would be interesting to the group. But in this study, again, healthiest diet, 11 to 24% lower risk of cancer death. And when it comes to cancer survivorship, those who follow a healthy pattern have a 17 to 18% lower risk of dying from cancer or other causes. Powerhouse. What we put in our bodies makes a significant difference. So cancer tends to be one of those triggering effects where some of my patients are like, they weren't willing to make some changes before, but boy, after they have something like that, they're coming and saying, okay, I'm ready. I really know this is important. So walking with them in this time is again, such an honor and a privilege and a beautiful way to help people shift in their health. The American Institute for Cancer put this out. These are the known 10 superfoods, and the word superfoods kind of cringes me a little bit because all plant foods tend to have a benefit. Actually, a lot of natural foods, or I shouldn't say natural foods, actual foods, nourishing foods have benefits. But there are these 10 outstanding ones that have been shown to reduce or to help with fighting cancer. So I'm going to go through these really quickly. So mushrooms, there's a lot of data on mushrooms, garlic, berries, turmeric, cabbage, crucifers, What else is in here? Leafy dark green vegetables. Love those. Can't get enough of those. Legumes, red grapes, walnut, celery. Again, these are all evidence-based backed, research-driven foods or information that we know about these foods. And again, just mainly from our talk today, I'm going to sneak in soy and flax seeds because you'll see there's just been some really exciting information about these two. We need a variety of foods in our diet. We can't eat the same foods on a regular basis. It's really important. We talk about eating the rainbow, eating lots of different foods. But again, checking in and making sure you're getting these foods on a regular basis is I think, a really good idea. Okay, so let's shift to menopause and perimenopause. And I just like this picture. Isn't she happy? Menopause and perimenopause does not need to be an unhappy time in our lives, but we need to understand it to make that transition feel good. So let's start with movement as we talk about different pillars. So exercise and movement. What is the research out there that shows movement improves our menopausal symptoms? Well, exercise can certainly help with physical and psychological quality of life in general, and definitely a risk for obesity, which in and of itself is an independent risk factor for a lot of things, but also to decrease or to increase your somatic symptoms during menopause or your symptoms for menopause. But unfortunately, there was no evidence of the effect of exercise on menopause-specific symptoms. I was surprised by this. I thought I'd be able to find something. And again, we know exercise is good for us, like we talked about our mental health in a lot of ways. And I still prescribe exercise on a regular basis. And I'll just, again, I don't mind sharing, have gone through perimenopause and menopause myself. And exercise is one of my anchors. I think, again, it's more for my mental health, which helps with my menopause shift. But again, we need to be open and honest about what we have in the literature and what we have in the research. So no specific research that shows that movement or exercise directly affects some of the symptoms of menopause, directly affects, but I think indirectly it may. So again, love or talk about nutrition, come back into this. So a whole food plant-based, and I like to talk about whole food plant strong because it doesn't have to be 100% plant-based by any means. But we do know that a whole food plant strong nutrition plan is extremely beneficial for preventing so many health issues and maintaining a healthy life. But let's talk specifically about menopause. Does it help with menopause? Well, we have great data on nutrition in menopause. It has been shown a healthy diet may actually delay the onset of menopause in the first place, as well as to lower menopausal symptoms all over. It's thought to be because the reason is thought to be because the antioxidants that are found in mainly fruits and vegetables. So again, some very exciting, happy news about menopause and nutrition. We do know a pro-inflammatory diet has been associated with a higher menopause-specific somatic symptoms. So what is pro-inflammatory? Sugar. Sugar is pro-inflammatory. A majority of animal products can be pro-inflammatory. Processed foods, ultra-processed foods, pro-inflammatory. So knowing these things and trying to, and we don't usually try to remove things from people's diets. What we try to do is crowd them out. So we start doing more and more plants and so much fiber that it's just hard to eat, and so once you get your good, healthy foods in. So again, it's exciting. So a very healthy diet will help with hot flashes, help with sleep issues. And so moving towards a plant-based diet packed with anti-inflammatory components like fiber and away from the other pro-inflammatory foods that I talked about before, which includes, high in saturated fat and cholesterol, that can explain some of the benefit that we see. So good news there. Again, I had found some information on soy. So soy and menopause, a study showed, again, a small study, 147 female volunteers, 90 of them went all the way through the study, so only 90 of them, but they did a regular consumption of soy milk to reduce the climacteric symptoms, and they reduced it. So what they took in was about 500 milliliters a day. So soy milk, 500 milliliters a day. And again, when we talk about soy, I forgot to mention, it's non-GMO and organic, because unfortunately, even healthy foods, this soy is processed, because we take the soybean and then we process it in the milk. There can be additives put in. So you definitely want to look at the non-GMO and organic if you can get it. But the soy milk at 500 cc's a day, right there, showed a decrease of symptoms of 20% in 12 weeks. So this wasn't long. So 3 months worth of taking in 1 cup of soy a day showed a reduction in some of these symptoms by 20%. Simple, and again, very exciting. So here comes our friend, flax. So I got to shout out another quick one to flax, but in a small trial of postmenopausal women, and this was inside of a lacto-ovo vegetarian diet. So it was plant strong, again, with lacto-ovo vegetarian. After 16 weeks, the diet that was rich in the omega-3s, which included daily flaxseed oil, here there's the oil, walnuts and almonds, did better at reducing vasomotor symptoms than a similar diet where they used virgin olive oil. So expressed virgin olive oil. So again, it was just interesting that that was the variable. And for menopause, decreasing the inflammation by using those omega-3s that were in the flaxseed, walnuts, and almonds decreased menopause symptoms. So good stuff through good food. Okay, well, let's see how we're doing on time here. We're doing well. Let's go talk about sleep. So I find sleep is a powerhouse pillar for change in this non-communicable disease preventative and treatment world of lifestyle medicine. But it hasn't gotten a lot of attention just because we love talking about nutrition and exercise and stress, all important, but sleep is just a powerhouse of what we can do. And traditionally, it's just given a little less attention. So I wanted to hit on sleep, and I'll just a few brief things. Firstly, sleep apnea. So sleep apnea is disordered breathing at night. The thing I like to talk about sleep apnea is if we don't ask, we don't know. And we know that as physicians and healthcare providers. If we don't ask our patients, sometimes they're not going to tell us. So we need to ask. And sleep apnea is a big consideration when it comes to women's health in general. Women may experience insomnia, daytime fatigue, and mood disturbance rather than snoring or gasping. So traditionally, and I'm going to talk about the disparities in research that have happened between the genders, but it is absolutely more undiagnosed in women because we think of the, kind of that stopped breathing, the snoring as a classic sleep apnea. But again, just like heart disease shows up differently in women, it's not the classic angina signs for a lot of women. Sleep apnea shows up differently. And again, insomnia, daytime fatigue, mood disturbances. We've heard this before. A lot of people will say, oh, that's just the time in life when you're tired. You have small children, you're tired. You're working and trying to take care of a home, you're tired. You have a lot of stress on your table, you're tired. You're going through menopause, it's a time to be tired. Again, I want to stop that thought process a little bit. And yes, there are times when we're tired. Men, the same way. If they're working 2 jobs, they're going to be tired. Or if they're stressed, they're going to be tired. We understand there's a lot of reasons for fatigue. But as healthcare workers, let's open our eyes, sit back and think, wait a second, could this be sleep apnea? Because a lot of women don't meet the typical profile. Weight changes that happen in menopause are another significant time that can cause sleep apnea. So it is more common in menopause. So again, we need to be thinking about this. There was a study of women's health across the nation, it was called the SWAN study, and they found that women who experienced menopause transition were at an increased risk of developing sleep apnea, particularly if they reported hot flashes and night sweats. So again, when we're taking that history and we're helping women, with some menopausal symptoms, please also consider sleep apnea. This is really important. Midlife is a critical stage for adopting healthy behaviors. As we saw on the beginning slide, at age 60, changing your diet really increased that lifespan. But do you guys remember? Actually, we can't talk till we'll talk about it. It was almost 2 years. So even at age 60, changing that nutrition, there was a strong change in nutrition, could have been anywhere from 1 to 2 years increase in lifespan. Changing and considering behavioral changes here, but considering sleep apnea here, that will have a profound effect on our patients, our women, their quality of life. So really wanted to emphasize that and point that out. Let's talk about supporting women during their sexual and reproductive health years. I love that picture. I found that picture, I just thought it was so fun. So I'm gonna pause just for the picture. But I like this picture too a lot. So sexual and reproductive health, it's an estimated 43% of women, irrespective of age, report sexual problems such as with desire, arousal, lubrication, orgasm, discomfort or pain, intimacy, and satisfaction. I'm going to pause there for a second. 43% of women across the lifespan report problems. So sexual health is a really important part of women's health care. Dysfunction is especially prevalent in women with chronic health problems, including metabolic syndrome, hypertension, dyslipidemia, coronary heart disease, diabetes, overweight and obesity, BMIs, anxiety, and depression. That sounds like a lot of people I take care of. So again, women with chronic medical problems are even at a higher risk for having sexual health problems. So interesting enough, and I want to touch on that because what I really enjoy about lifestyle medicine, and I like using my hand, and hopefully you guys can see me, is the root cause. When we get to the root cause of an issue, let's say sleep is a root cause of an issue, a bunch of these symptoms go away, and we still might have one symptom that we want to deal with in another way. But when we get to the root cause, it's so much fun that multiple things will start to improve. Again, when we talk about cardiovascular disease, cancer risk, diabetes, when we start changing these behaviors, things get better. And that's the fun thing. Sometimes I'll have women report and men report that as they've been working on their cardiovascular health or recovery or wanting to prevent cancer, et cetera, their sexual health has improved, and it makes sense. So think about a root cause. So maintenance of good cardiovascular health can support sexual function, including avoiding painful intercourse. So if you have a woman who's talking about painful intercourse, think from a cardiovascular perspective. Having low atherosclerotic burden and adequate nitric oxide activity are protective against sexual dysfunction. So interesting ways of thinking about this. Positive mood has been associated with increased sexual desire and arousal at a happier, more positive experience for sexual activity. So I have a t-shirt that says good food, good mood. Good food, good mood. Good mood can be associated with, it can be an adjunctive treatment to women experiencing low mood and sexual dysfunction. Specifically, I'm going to touch on the Mediterranean diet, which is a diet that has emphasis on vegetables, fruits, nuts, whole grains, legumes, olive oil, and fish, similar to what we talked about in another study there. It's very high in antioxidants and low in saturated fats and refined carbohydrates. And that specifically, the Mediterranean diet has been studied and shown to result in better sexual function in a dose-dependent manner, regardless of menopause and metabolic syndrome status. Again, changing your diet has many effects in our body. I'm going to briefly touch on some specific areas in sexual health. So fertility, we do know obesity has an effect on fertility, but so does being underweight. So a BMI of less than 19 or greater than 25 had a relative risk of time to conception of greater than 12 months of 2.2 in the relative risk factors. So again, the different areas around weight is specific around fertility. Tobacco, again, they say it hits different areas of lifestyle medicine. The toxins in cigarette smoking have been correlated with subfertility, endocrine disorders, earlier onset from menopause, premature ovarian failure, and decreased implantation rates. So again, when we're thinking about our reproductive health, really think about the whole spectrum of lifestyle medicine. Tobacco use is also associated with many early pregnancy complications, including spontaneous miscarriages, bacterial vaginosis, preterm labor, and ectopic pregnancy. So our bodies need to be healthy and want to be healthy to carry a healthy child to full term. Nutrition, let's talk about specific nutrition again, and when it comes to optimal fertility. There is something called a fertility diet, and this I read a lot about, and it's not exact. There have been different groups that have really tried to come up with what this is a fertility diet. But in general, it's composed of plant proteins, full-fat dairy, non-heme iron, which comes from plants, monounsaturated fats, low intake of trans fats, low intake of animal protein. Anyway, in general, this diet had a 66% lower risk of infertility related to ovulatory disorders and a 27% lower risk of infertility from other causes when compared to women with the lowest intake of this diet pattern. So again, you're going on the both spectrums, but when you put it from this poor nutrition diet to this more optimal or feasible diet, really, a significant difference when it comes to fertility. So just some things I wanted to shout out there. Let's go to another question, and we're gonna end here with epigenetics. I'll probably have about 4 or 5 more minutes of information, and then I want to open it up. So tell me, what is epigenetics? What is that? Is it the study of changes in organism caused by modifications of the gene expression, DNA and RNA replication, genes and genetic variation and heredity, or diseases and how much it spreads? Okay, you guys are great. I love. Thank you for all this. And I tried to make them not tricky, but just very somewhat similar so we could have a discussion. All right, thank you. So it looks like about 30% had the correct answer is number 1. Epigenetics has to talk about the changes in organisms caused by the modification of gene expression. So epigenetics has more to do with gene expression. So RNA and DNA replication, that's what happens in our cells when they replicate. Genes and genetic variation of heredity actually has to do with genetics itself. And then epidemiology is the disease and how it spreads among populations. And again, I just kind of cropped down those definitions, so nothing too specific there. But the key here is epigenetics really talks about the power of the science behind modifying the disease and the outcomes through behavioral change, which is lifestyle medicine. So we really talk about how can we modify how we express those genes. So I want to touch on an interesting study, and again, very small study, directionally, I think interesting, but it has to do with what happens during pregnancy. We do know that what we do when we're pregnant as women, when we have this child growing inside of us, what we do can affect up to 3 generations. 3 generations. I always laugh when I found out about this. I had already had my first, actually but just was having my second child, and I was like, put him back in, I can do better. When I found out how much of an effect that is. But an interesting study, and it's more of a hypothesis, because there was a lot of factors that were controlled for, but they looked at the maternal protein intake during pregnancy. And if a woman had more of an animal source protein, primarily meat proteins, wasn't related as much to dairy, but was more of an animal flesh and animal meat, there was a significant increase for their children growing up overweight. And the weight gain was related, again, more to meat than the dairy. And this was independent upon how many calories they ate or how much they exercised. So it really had to do with what they were intaking, and it was interesting there about animal protein. Said that the subsequent generation was overweight or obese, and the impact was noted more on female offspring. Again, I can't explain why. I just think it was an interesting topic to look at from an epigenetics perspective. So health disparities. There are definitely efforts being made to ensure that lifestyle medicine interventions and healthcare services are accessible and effective for women of all backgrounds and socioeconomic status. The, again, exciting thing about lifestyle medicine is it can be applied to any gender, at any age, and any healthcare delivery system, and by any level of the healthcare team. This is medicine that affects everyone, which is really, really exciting to me. So in the US, there are definitely some lifestyle medicine inequities, racial and ethnic minorities, particularly the Hispanic and Black women, and those with lower income and educational attainment face the greatest of barriers to achieving the lifestyle goals. And it is, the awareness is really important to understand this. And what we see is there's, in general, in these populations, there's a lower awareness of the impact of diet. So just the understanding and awareness, disparities in the availability of high quality foods and preventive healthcare. So not just reactive healthcare, but preventative healthcare, which is what we all have been talking a lot about today, and we like to practice. And then because of that, there's a resultant discrepancy in rates of obesity. Demographics ultimately play a large role in conferring the access to a healthy diet in the US, and this was US specific data. Also, there are research inequities. So not only about just clinically obtaining good lifestyle medicine, but when we look at the research, we know that in the United States before 1993, women were rarely included in clinical research. I think this is important to understand. I mean, obviously, which is why I'm putting it in the slideshow. Men were looked at as the default human, and women were considered a special population. This was, again, up until 1993. Also, so you can understand why this might have happened. It's not a blame game. Let's just have an understanding. Women are different than men, right? We are. So when you do research, you're introducing more variables by having both genders. So I think that it was easier for people to study men at the time. So that made sense. Then in addition, there were intentional research policies that excluded women. So in 1977, there was a drug called thalidomide, which I think most of us still remember. It was produced for morning sickness, but it was found to cause devastating birth defects and even death in babies. Then there was a policy written to exclude all women in the reproductive potential stages of phase 1 and phase 2 clinical studies because of this. Accordingly, then that spread, and it was felt that any premenopausal women may be at too high of a risk to include in any study, so they weren't. So again, good reasons potentially, but then that spread to women not being in the clinical studies. And so then we were inferred to be similar to men when it comes to outcomes and application of what we learned from research. But now we understand that more than half of the population, women, who are unique, need to be specifically studied and intentionally studied. So recently in the United States, $200 million in additional funding was given for use in 2025 to allocate to the NIH-wide effort for interdisciplinary women's health research. So again, the awareness is there. We're understanding why it is there. We're understanding that we need to be specific about our intentions. So together we're changing the trajectory. And again, we're doing it intentionally. So if you are in research, just make sure you're recruiting as equitably as possible, but not only recruiting into the studies, but also reporting out your findings based on gender, race, and socio determinants of health, if possible, because we need to identify specifics in this area. Obviously, in specifics in health. I'll just quickly mention HEAL. It was a project through the American College of Lifestyle Medicine, Health Equity Achieved Through Lifestyle Medicine. They have 4 points of focus. They're looking at our federally qualified health centers and community health centers, clinicians with free lifestyle medicine education to all of the providers there in those centers. So again, this is really trying to improve the spread of lifestyle medicine in an equitable way. We're identifying lifestyle medicine in the workforce and trying to diversify it intentionally. The group that makes HEAL up, HEAL, has monthly meetings to discuss unique and effective ways to reach identified and medically underserved communities experiencing things like food insecurity and the other social determinants of health. And then we really are looking at all of the ACLM materials and resources to be filtered through a social determinants of health lens to ensure they're created with a health equity focus. So again, just being intentional and thoughtful about understanding where maybe our weaknesses are and how to overcome those. One of the things I think is the most important thing when it comes to health equity and understanding some disparities to really spend time outside your own box. It's a challenge for all of us. We've all had our own family of origin. We've all had our own experiences, and that's beautiful. That's who we are, and that's what the world needs. We need to bring each one of us into this world. But from the interconnectedness that we understand, stepping outside of our own boxes, learning, living, talking with, experiencing life with others that are different from us is I think the most significant way for us to reach those goals that we hope to attain. So I hope I didn't speak too fast, but with all of that, I thank you for the opportunity to join you in this greatest pursuit of improving the health of our globe and the people through focus on lifestyle medicine, and today through a focus of women's health.
So Dr. Mechley, thank you so much for that wonderful session. And of course, women's health is such a broad topic. So even what you covered in the 50 minutes, that's monumental. So I'm just going to start with a few questions that we started getting in, and we'll try and go through these as much as we can. So, we are getting some general questions. If you don't mind, I will put those to you, since you're a primary care physician. So we have some of our attendees, she's asking about, the stress you go through during the period time, the aggressiveness, or does lifestyle or nutrition, do they have like a role to, help address that?
Oh, it's a great question. And I'll reflect back on the question. So I think it sounds like during premenstrual time. And so there's something called premenstrual dysphoric disorder, or sometimes there's an emotional lability that happens for some of us during it's usually the week before menses, sometimes during menstruation. And then for some women, it's even after menstruation. They can have, because again, what we're going through is we're going through some beautiful variations in our hormone levels that are telling our body, hey, it's time to do this, it's time to do that. So we know that that's what causes some of those changes, is that variation. So lifestyle medicine absolutely has a role to play. When we have a pro-inflammatory body, when our body's under inflammation, those spikes and valleys might hit us a little bit harder in areas. Because estrogen doesn't just talk to our ovaries, estrogen talks to our brain, estrogen talks to our gut, progesterone, same thing. Their hormones is a word for messengers, and they're giving messages throughout our body. We tend to study and pay attention as a reductionist model to this is our genital area, or this is our the sexual organs, and I always like to tell brain is a big sexual organ for both men and women, and we tend to forget that. So those hormones have an effect everywhere. So in general, to answer the question, if you can stay in a lower inflammatory state of being, it should help shift that. meaning that if I'm not putting in a lot of processed foods and a lot of sugar, I find sugar and dairy to be two of the biggest effects when it comes to nutrition on what our baseline is. And when I have people choose to take that out of their diet, I say, let's just try it for a while. Let's see. So for women, let's go through the next 3 cycles or 2 cycles trying on a lower inflammatory diet. And everybody's like, what exactly is that? And it's just the stuff we love to talk about. High fiber, taking out a lot of those processed foods, but specifically sugar and dairy. I find that there's less in general emotional lability, etc. So that would be that again. And there's other ways of creating lower inflammatory states. Meditation, can be really helpful at that time as well.
Sure. Thank you for that, Dr. Mechley. So just talk a little bit more about nutrition. So of course, intermittent fasting, a lot of people are moving in that direction. A lot of people are being advised, especially for people who are struggling with weight loss. So the question is it, is when to eat as important as what to eat? So again, I think the question is more in relation to intermittent fasting.
Right. No. So hell yeah, we and I could stay on. We could talk forever. This is so much fun.
Yes.
So one of the things I just want to, from a terminology perspective, fasting doesn't happen until about 72 hours in our body. So when we use the term intermittent fasting, it's more of a public term that is not scientifically correct. So timed eating is a way of talking about that when we're talking about from a scientific perspective, but our patients will talk about it as intermittent fasting, as you know. So usually timed eating is like, I'm going to rest my gut for this many hours, and I'm only going to eat for this period of time and within a 24-hour period. And a lot of people will do it like from 10 a.m. to 2 or 10, whatever it is. And there are some really interesting research studies about that. So I think for a lot of people that can be very helpful. And I think it's a cognitive way of defining a behavioral change. So it's, make it visible, the invisible visible. We're better at making changes when it's visible. So I think that's one way that it helps people with weight loss, because they're saying, oh, it's after 7 o'clock. I've told myself I'm not eating after 7. So it kind of cuts down on some of those things that we want to be good at, but we have a harder time, doing. But to answer the bigger question, it is true. A calorie is not a calorie. So a calorie that comes from a sugar source or a processed food that also comes from an apple, it's not the same. Our bodies see it differently. So that was old dietary advice that I would love to pull out of the current knowledge base. So even though if you want to count calories, we really have to be more thoughtful about that and think about where you're getting the calorie from and what it does in our body. But I also have seen great studies that a calorie eaten in the morning will affect the body very differently than a calorie eaten in the evening. And that goes back to that adage, eat, like I think a king for breakfast and a prince for lunch and a pauper for dinner. I've heard that before. But if you get the majority of your calories more in the early daytime, I think our body then, just from a logical perspective, and I always be careful because science is not logical. We have to study it. We do that sometimes. Well, that's logical. That's the way it's going to be. Not true. Not true. We have to study it to be true. But a calorie in the morning, your body is going to use that throughout the day. A calorie in the evening, we're not doing as much. So that's just the way it makes sense to me. But yes, we do know a calorie eaten at a different time of the day does affect the body differently.
Okay, great. Thank you for that. So let me talk, ask you a question again, just related to nutrition. And in what ways, you did mention to some extent, but what ways does diet really influence hormone balance and reproductive health in women? What role, I mean, you have gone through, but if you could just reiterate some of that, especially related to hormonal balance.
Mm-hmm. It's interesting. I get a lot of women who come in and say, I want my hormone panel. Can you test my hormone panel? And I always smile and I'm like, do you know how many hormones are in the body? There is no such thing as a hormone panel. But what they're asking for is really around, the sexual hormones and things like that. Yes. Because, we're either feeling irritable, we're feeling unhealthy, we're feeling overweight, and we're like, it's got to do something with the hormones. And the thyroid hormone probably has the most to do with our metabolism. But again, it's beautiful. The hormones are just a fun bunch that go around doing a really, really good job. So when we talk about nutrition and the hormones, it's like anything else. Our body really wants to go to what's called homeostasis. Our body is just, it's a beautiful healer in of itself. And a lot of times what we want to do is you just need to support that process, and we need to get out of its way. So we want to support that process by giving good fuel. really healthy, clean fuel. And when we're putting things in our body, let's say like a processed food, I'll go real bad, Twinkie. You know, I don't know if you guys know like a packaged food, etc. I always, again, and this is not scientific, but the way I explain to my patients, when you're putting it in, your body's going, I don't want that, you take it. I don't want it, you take it. I don't want that. And the poor liver's got to go, well, let me process it and see what we do with it, you know, or after it goes to the stomach, etc. But it gives a visualization to that's not really doing anything for our bodies except we're defending against it. So the hormones are very sensitive. They're very sensitive. So when you put things like that in our body, they're going to get a little irritated or irritable. And again, I'm using large, funny things and not as scientific. So to go back to just really wholesome, whole foods, plant strong, clean, unprocessed foods, you can give me the same question and almost put in a bunch of different words. How do we keep our hormone balance? How do we keep this, our brain happy, et cetera? And that's all hormones, because hormones are exactly what's telling our cells what to do. So I think that is absolutely key. I had another thought when you asked that question I thought would be more important about hormone balance. It was weight. So we do know when we carry, just take fat tissue and put it on my body. When I carry more adipose and just put it on my body, that also confuses the hormones. And that's what we know about pre-diabetes and diabetes. The insulin, which is a hormone, gets affected just because of the extra weight on our bodies. So that's where, you know, the keto diet became really popular, because everybody's like, oh my gosh, and you will lose weight on a keto diet. The concern that I have with the keto diet, short term, you can get some effects. Long term, we do know from the studies, it actually increases our chances of disease states. So we might lose weight, but we don't want to go into cardiovascular disease. We don't want to go into later diabetes, because it is more of a pro-inflammatory in general, than a whole food plant strong. So again, there's not one perfect diet for everybody, and there's not, you know, it's this and not this. I think we have to be thoughtful about nutrition, but weight loss does help. It does help when it comes to fertility, when it comes to our hormones, when it comes to having regular periods and ovulating on a regular basis because of those hormone effects. So again, getting our body to homeostasis, which is not a perfect weight, it's just a nice balance. And I don't want to go on too much, but because I know there's more questions.
Yeah, we can just do a couple more. I know we've crossed the hour, but I'll just do a couple more. So we did have a question about asking about the role of evening primrose oil in menopause. If you can please address that, if you don't mind.
No, and I
specific question on.
I know, and that is something I've heard. I don't have the statistics on my head. Yeah. What I usually tell people about certain types of nutraceuticals and supplements is I'll look it up with them, and I say, if it's not harmful and I don't find any harm, try it, but not in absence of other things that we know are helpful. So if someone says, I want to continue to eat unhealthy food late at night and continue to be, you know, overweight by 60%, but I want to use primrose oil to help me with my menopause symptoms, I'm fine. Again, I'm fine with it. And I think there are some studies that will show a positive effect for primrose oil. But you have to be careful about how you take it and when you take it. So please be thoughtful about that and look that up at a good source. I have a good source that I look up a lot of those nutraceuticals. And in general, and I'll throw this out to the audience. Well, let me pause on that for a little bit. I'll finish the answer. So I think that if it's not harmful and it's not distracting, because harmful is not just harmful to the body. It can be harmful in a way that it's distracting you from the goal, the true thing that will help you the most. But honestly, there is not good scientific studies on most supplements. None. You use the supplement study that will say, we know this element like leucine. We know leucine is good for the brain, which is in a tomato. So I say eat a tomato. But then they'll have these supplements that have leucine in them, and they'll say, well, what about this? And I'm like, well, I don't have any evidence that shows that actually does the same thing that the tomato does. Yes, you can eat it. You can find it in the blood. You can find it in your urine. You can find it higher. But do we know on a cellular level and at an outcomes level that does the same thing that eating a tomato does? And I would challenge, I would love to find really good data about that. I have not been able to find any of that. So I think it's important just to go back to the whole foods.
Absolutely.
In general.
Yes, absolutely. Thank you. So just another question about flaxseed, since you did mention it a few times in the presentation also. So the question is, can we eat it daily, and what's the best time And again, I know you mentioned in some place ground flaxseed, and in some place might be full. So what is, your take on flaxseed intake?
Yeah. So the studies that I looked at, and again, they were specific to disease states, some of those studies about menopause or osteoporosis, et cetera. But it was exciting. I mean, to see that this little powerful seed, and I've really started to study a lot of seeds a little bit more specifically. But so the things about flaxseed, number one, ground. So if you eat a whole flaxseed, it's going to be good fiber, but
Right.
most of those will not be broken down. So you're not going to get to the omega-3s on the inside.
Sure.
So anytime you eat flaxseed, in my opinion, if you're trying to get it, and again, there might be studies that say it's better for whole for certain things. I don't have those at my fingertips, but I would say try to grind them and freshly grind them. And then again, I think I quoted some studies that said anywhere between a teaspoon and a tablespoon a day. And that was, again, more for specific for treatment. I want to take a moment and mention this. When it comes to lifestyle medicine, it's very similar to anything else. When we talk about intervention, the dose and the dose and the timing, just like if I was treating high blood pressure, I might say this medication at this milligrams once a day because I'm treating high blood pressure. But when you're preventing something, it's a different dose and it's a different time. So I think in general, flaxseed would be a good part of a whole diet. And it's a great place to get some of those omega-3s. So a daily, I don't have an issue with that. But again, we have to be thoughtful, like anything else, especially when it comes to nutrition prescriptions. There's prevention, there's treatment, and there's reversal. Sure. And the reversal dose is going to be much more intense, as you know, with the ITLCs that we talk about, much more intense and much more specific. Prevention is going to just be that I'm preventing something, so it's usually a little bit different.
Okay, great, thank you. So a question just about menopause and experiencing sleep deprivation. What are some of the practices we can do, for good sleep hygiene, or is there like a supplement that you can give for, to help with sleep deprivation?
That is a 2-hour talk I gave about a month ago. So I was like, oh, be careful what you ask. I can go on for 2 hours. Okay, I'll try to encapsulate this very briefly. And it's boring. It's the same thing I say about everything else. It's like, okay, guess what? It's going to be good nutrition, exercise, etc. So yes, when it comes to sleep, we know there's sleep hygiene. Screens are one of the biggest issues. Our circadian rhythm, knowing there is no catching up. You really do need to go to bed at the same time, wake up at the same time. Keeping that, we're sending signals to our body that they're so confused. All these lights at night, et cetera, et cetera. So some of the basics are just, the basic sleep hygiene. Absolutely. Menopause throws a little bit of a change in there. So then you're going to have additional things like an increased weight potentially, but that's where weight training, I cannot impress upon enough. Building muscle is so important, especially at midlife. But in general, for most of our lives. But at midlife, we do understand that the sarcopenia happens. We start to lose the muscle on our bones. So we have to be intentional about bringing that back. So you're thinking, okay, that's great for osteoporosis. It's actually really good for sleep. So it's good for in so many different areas. So being physically active, maintaining stress levels. So lifestyle medicine is the key for sleep. But I think the awareness is, and what I tried to talk about here is not just to say, hey, you're a woman, you're busy, fill in the blank, blah, blah, blah. So we understand that you're tired. Wait a second. Let's really ask. I'll give you my favorite assessment. That actually probably the easiest thing to do. There's something called a consensus sleep diary. I have started to use that about 10 years ago. I don't remember, many years ago. And I find that to be the most important when I'm working with patients around sleep, because it's a 7-day, very specific. I think there's 11 or 12 questions that they fill out. Because what we used to do with sleep is say, oh, here's melatonin. You just need to do this. You just need to turn off your screens. Just like anything else, we need to assess what is the issue first before we give advice. So that assessment has really helped open my eyes to, oh my gosh, you're actually having a hard time falling asleep. Or you fall asleep fine, you're having a hard time staying asleep. Or for men, you get up 3 times to go to the bathroom. Even when you get up 3 times to go to the bathroom, it's actually sleep apnea. You stop breathing, you wake up, and then you realize you have to go to the bathroom. So it's not the fact that men have a prostate issue or women have a weak bladder. It's the fact that they have sleep apnea that's undiagnosed. and they're cognitively waking up, and then they realize they have to go to the bathroom. And we just we assume it's one. So I would just say that the consensus sleep diary is an assessment tool, and I think it's available publicly. I hope it is. I'm not saying about it. I believe it is. And that again, figuring out what the issue is with sleep. It takes time. This is a pillar that takes time, but boy, the rewards are huge. And then really working with somebody. And then cognitive behavioral therapy for insomnia has been another really important intervention for people who are truly having more of a sleep disorder, insomnic issue, or even where it's the delayed ability to actually fall asleep. But I could talk more.
I'm just going to ask one last question. I know we are 10 minutes over, but thank you so much. But I just want to ask, because this is such a common, and very common now with, so basically talking about, given the increase in using GLP-1 agonists for weight management and obesity, what would be the recommendations for incorporating lifestyle programming and the use of GLP-1 agonists in patients?
What a great question. I love these questions. So I studied, and I went to two of my very close friends who happen to be board members or other people in the global lifestyle medicine arena who are obesity specialists about a year and a half ago. And I said, I need to really deeply understand this research to put the best protocol. So I put a protocol together for my practice. So I do have a few patients on GLP-1s. And the key components that I would love to highlight are, one is the protein, the intake of protein. So typically, and this is still a little controversial, but when it comes to lifestyle medicine and doing weight loss with a GLP-1, we do know that most people need to increase their protein, and it's usually up to 1.8 grams per kilogram. Did I say that right?
Okay.
1.8, yeah, grams per kilogram. Yes. Think about that for a second. Where the normal is about a 0.8 for most people. You'll hear people speak of higher elements than that or lower. And it is very difficult to get that much protein from a 100% plant-based diet. I've got protocols written out. I've got handouts. I've got things that people can do, but you have to be super, super intentional, and you have to eat a lot of food. Because if you are morbidly obese, and if you think about, I have to do 1.8 grams per kilogram, my kilograms are up, I'm eating that much more food. And I tell my patients, hang in there, do the best you can, because as you lose weight, it'll get more manageable. But I do talk to them a lot about lentils and, other things that are really protein packed. So again, doesn't have to be 100% plant-based, but we do know from the inflammation, et cetera, I would love the majority being plant-based. And then it's, some cleaner, maybe animal-based proteins, adding that in to maintain that. And the big reason behind that is the loss of muscle mass. So 40% of people on a GLP-1, their weight loss 40% of the weight loss comes from muscle. That's huge. That is so significant. And a lot of people don't understand that. On a GLP-1, you're going to lose weight, but 40% of that is muscle. So we really have to work against that by really increasing that protein intake. But that's only the first part. If you just did that, it was not going to work. The second part of that is to do resistance training. You have to then turn that protein into muscle. So I have people on a very specific protocol where they're doing resistance training, either with bands, their own body weight, or dumbbells, actual weightlifting, where they have a very specific program, at least, it's 2 to 3 times a week, depending upon how they do it. They can do it every day if they're rotating the body parts, but if they're going to do a whole body strength training workout, they're going to do it 2 to 3 times a week. So it's a combination of increased protein. So again, from a nutrition perspective and an exercise perspective. And then you've got the connectedness and stress. I mean, all of those things. So every pillar of lifestyle medicine is involved in this. And we put that in our protocol. But those are the two key factors that I think are really important when we're using this medication.
So thank you so much again, Dr. Mechley. We are really, really glad, you could take some time out from your schedule and do this session for our attendees. It's been great. Thank you so much.
Thank you. I appreciate the time and the camaraderie.
And thank you to all our attendees, who attended from different parts of the world, of course.